Yes, Deepa. Yes, ma'am.
Ma'am?
Good evening. Good evening. We are giving an introduction. Raji?
Yeah. Yes.
Okay.
Ma'am.
Okay, start.
So, can we start, ma'am?
Yeah.
Yes, ma'am. So, a very warm greeting to each and every one of you. Welcome to today's session on nutrition interventions in dysphagia care. I am Rajeshwari Anand on behalf of the organizing committee, Good Monknutrition, Netprofan, and Indian Dietetic Association Chennai chapter. We extend our appreciation to all of you for joining us today. We start the session with the Tamil Thai Valtu. Thank you, ma'am. We now welcome Mrs. Deepa Govindarajan, our co-convener of Indian Dietetic Association Chennai chapter, to give the welcome address.
Good evening, one and all. A warm welcome to the nutrition interventions in dysphagia care. It's a great pleasure to welcome our speakers of the day, Mrs. Srimati Venkatraman, clinical dietitian and wellness nutritionist, founder of Mita Ahara, and Dr. Madhumita Krishnan, consultant Ayurveda, pediatrician, childbirth educator too. A warm welcome to our moderators, Dr. Meenakshi Bajaj and Mrs. Sheila Krishnaswamy. Mrs. Sheila Krishnaswamy has been also a former national president of Indian Dietetic Association, and she's a diet and nutrition wellness consultant. Dr. Meenakshi Bajaj is a co-convener of Netprofan Chennai chapter, and also a member of the National Executive Committee of Indian Dietetic Association. A warm welcome to all of you. A warm welcome also to Mr. Pri Krishnamurthy, sir, who is the convener of IDA Chennai chapter. Warm welcome again to Dr. V. Bhavani and also all the members from the Good Monk Nutrition and the tech team. A warm welcome to all who are participating in today's program. So we can now move on with the agenda. Thank you,
ma'am. Thank you so much. We have two sessions today. With the opening session, as with the famous philosopher Kant has said, theory without practice is empty and practice without theory is blind. We start our first session with Mrs. Srimati Venkatraman, clinical dietitian and wellness nutritionist, who will be speaking on the nutrition interventions in dysphagia. The chairperson for the session will be Mr. Krishnamurthy, the convener of Indian Dietetic Association, who has 35 years of experience as a chief dietitian in Vijaya Hospital and nearly 17 years of teaching experience, got many awards to his credit as best dietitian, and currently working as a senior consultant dietitian in Venkateshwara Hospital at Jain Diabetic Research Hospital, and has got many articles to his credit and many presentations also to his credit in all the Vigadan magazines and Dinatandi, Daily Malar, Indian Express. We welcome you, sir. for this session as a chairperson. We also welcome Mrs. Dr. Meenakshi Bajaj, registered dietitian, who has many.
You're muted, Raji.
Adu, Chief Dietitian of Tamil Nadu Government's Multi-Super Specialty Hospital, and a former dietitian of Rajiv Gandhi Government General Hospital, Madras Medical College, a member of the Indian Dietetic Association and the former convener of Indian Dietetic Association. She is the treasurer of the Association of Diabetes Educators, a reviewer of European Journal of Clinical Nutrition, Diabetes and Metabolic Syndrome Research and Reviews, and a reviewer of Journal of Diabetology. And she is the member of the District Advisory Committee, Eat Right Chennai, Department of Nutrition and Dietetics, Periyar University, Department of Food and Nutrition, Gandhigram Rural University, and the member of the Ethical Committee, Home Science Department, Women's Christian College. And she is the author of two books, Diet Metrics and Two Lies Twice as Precious. We welcome you, ma'am, to moderate this session. Over to you, ma'am.
Thank you so much. At the outset, I'm truly grateful to Indian Dietetic Association Chennai chapter as well as Good Monk for providing me with the opportunity to moderate the session on dysphagia. And we have an excellent speaker with us today who will be taking us through the journey of dysphagia. I would say through the journey of dysphagia from theory to practice. It's what we read is different from what we practice. And she's one person who has not only experience with reference to dysphagia, she has several certifications, international certifications also from the dysphagia societies across. She has 23 years of experience in clinical dietetics. She's the founder of Mitahara, Most Promising Nutrition Consultancy Companies of 2023. She's a visiting lecturer for Manipal College of Nursing. She has several textbooks to her credit. One of the toughest textbooks which I would think of when we were studying in UG or PG was biochemistry, and she has published a textbook on nutrition and biochemistry for nurses. And she also has to her credit a neuronutrition booklet. She's contributed to several articles both in press and online. And obviously she's a member of several prestigious associations. Now, with reference to dysphagia, I would want to make a mention here is definitely it has been derived from a Greek word dys and the phagia. So both of them talks to us about the difficulty in eating as well as swallowing. So this is difficulty, phagia is eating or swallowing. But one would always understand, those who are not working in the area of neuro or head and neck cancers or with the upper GI tract complications, one would only think that, oh, it's just a swallowing disorder with reference to solid foods or semi-solid foods. In fact, a short two-liner I would want to make a mention. I had a patient who was in coma for a period of 6 months. She came to us with multiple pelvic fractures, multiple rib fractures, and we weaned her off all the coma, and she finally managed to eat and swallow. But unfortunately, her peg was still on just to feed her water. Those were the days when we did not have thickeners. Thankfully, now India is flooded with a market of thickeners. So we just had to have a peg tube only for feeding her water. One would understand the importance of water from UTI to AKI to sepsis, and the list may just go on. So it's not only always associated with dysphagia, with neuro complications or with head and neck cancers. We have so many other areas wherein you would find dysphagia. Also, one important things which are left unnoticed are like hypokalemic periodic paralysis. I do not know how many of you have patients seen with dyselectrolytemia, whereas with hypokalemic periodic paralysis, you see upper and lower limb paralysis. But add on, there are few case reports wherein you have dysphagia also. You have the most common Guillain-Barré syndrome, which is obviously a neuro complication, where you would also find dysphagia. So the list is just never ending. Something as simple as eosinophilia, tropical eosinophilia, you have esophagitis associated with dysphagia. You also have GERD, as simple as a GERD associated with severe esophagitis and gastritis, wherein you have dysphagia. I would not, hold my audience here from listening to Srimati. She's authority when it comes to dysphagia, and right now she's heading the special interest group in dysphagia, and we are waiting a lot of consensus guidelines from Shri and her group. Over to Srimati.
evening, all. Thank you so much, Good Monk, and especially IDA Chennai chapter. I'm speaking among stalwarts here. Meenakshi, thank you for calling me. Krishnamurthy sir, hello, my mentor, and Sheila ma'am, everyone. So I'm talking to a lot of people with experience here. Thank you so much for the opportunity. And let me share my screen and start it. Maybe the questions can be at the end. Please note it down, and I would be very happy to share many things, because this is a very upcoming field, and I want all the dietitians to look at this because it is very common nowadays, and this would help. Thank you. Okay. So can you see my screen?
Yes, ma'am.
Able to see my screen?
Yes, ma'am. Yes, ma'am.
Yes, ma'am. Yes, ma'am.
Okay, so let's start with the dietitian's role in the management of dysphagia. I have two sets of slides, so bear with me, two PPTs. So you can see, look at this esophageal web and other things, and I will explain it down the line. So the learning objectives today is the prevalence, the signs, evaluation, how to evaluate the dysphagia, the difficulty in swallowing, nutrition risk, dietitian's role, multidisciplinary teamwork, meal times, what are the best practices, and theory versus practical setting. So the prevalence of dysphagia is 1 in 17 people worldwide. So it is some form of dysphagia in their lifetime. It's not only clinical conditions, it is also in the seniors in old age homes, or whether they are living with you. It is very common, especially after COVID. People have understood how difficult it is for the loss of smell, loss of taste, and COVID population, post-COVID population also has a lot of dysphagia. 1 in 25 adults annually are diagnosed, which is almost 6 to 10 million. It's not only in Americans. Please go to WHO website, where I think people are aware now that 2050, there is a commitment from the world organizations, the UN and the WHO and the FAO, and other thing is to bring nutrition security and other things. This is also one of the thing is the aging population in the world, and in India by 2050, almost it is going to double. The number of old age people in old age persons in India is going to double. You can see the NFHS and also the government website, where they have seen that it is going to triple in population, the geriatrics population. And also the main thing is the disability, how we are not equipped to look at different requirements of the geriatric aging population. And one of it is government has put forth a lot of initiatives to say that we need the health workers to also come up with a lot of ideas to manage this, to provide better quality for this aging population. No statistics are available for the Indian population. Why this matters? Because malnutrition is a big problem in dysphagia. So the complex process of swallowing. So I'm only talking about adults here. I'm not talking about pediatrics, because pediatrics is also about half a day of workshop, where from neonatology to infancy to growth years to toddlers, and it becomes complicated. So let's look only at adults today. Dysphagia is divided into oropharyngeal and esophageal dysphagia. Oropharyngeal, its condition is recognized by WHO. Difficulty or inability to move a bolus, which is like maybe a spoonful of your food in different consistency, safely and effectively from the oral cavity to the esophagus, and can include aspirations, choking, and residue which is left. So we take swallowing so much for granted. Only when we see traumatic brain injury, when you see neurodegenerative diseases like ALS, multiple sclerosis, all these Parkinson's, which is a progressive disease, definitely, and Guillain-Barré, which Meenakshi also mentioned, you the first thing within 2-3 days before the immunotherapy has started, we have to anticipate, yes, there will be dysphagia, and not try to give orally the first 2 days itself. Swallowing involves 55 muscles, 5 cranial nerves, 2 cervical nerve roots. Cranial nerves, that's why even in stroke, post-stroke rehabilitation, depending upon the infarct, where the brain has an infarct, there is a dysphagia, and it depends upon where the infarct is. So what is the symptom of dysphagia? Coughing and choking, onset of breathlessness, unexplained weight loss. So what they do is they try to keep eating whatever they can, and you would have seen people coughing and doing like this, just patting on the head, the senior population at home. They will just think, okay, somebody's thinking of me, that's why I'm coughing and all that. But actually it is because of their dentures, they're not chewing, they're swallowing not properly. And also the other one is they have it, they don't want to share it with the family because they don't want to burden the family. So when they eat, every mouth they keep drinking water to push the food or the bolus inside the food pipe. Gurgly voice because there is residue left. Having difficulty chewing. It is very difficult to chew the food even in a normal adult population because of dentures not properly placed. Teething and also drooling occurs, especially in stroke patient based on the infarct, and there is a stuck food in the throat. If symptoms of dysphagia are ignored, it can result in aspiration pneumonia, which is life-threatening, and that is how the people land up in the ICU even after discharge. So I'm just going to play this video to see first how the normal swallowing is, and then how it is with a thickened bolus. It takes that long for one bolus to go in, and you can see how much we gulp, we take swallowing for granted. Why I got interested in dysphagia, since I work with a lot of neuro cases also from the beginning. Actually, when I started my career in Chennai, I worked in a public health center with a neuro disability, with a neurosurgeon and a neurophysician, actually, with Krishnamurthy Srinivas. He's not there anymore. But that was my first thing. So somehow I think there was a signal. I started with neuro, and now I'm in a multi-specialty. Down the line, I've worked with lots and lots of neuro cases. And when they cannot swallow, you can just see how difficult it is. Even when a patient, before they get admitted into a hospital, the first thing they say, when a child, when a father, when a mother, when a daughter, all of them, oh, they've not, they're so concerned. Any one of us will be okay that they've not eaten. So the first thing, even in a stroke or any condition, is when are you removing the right tube? When is he going to eat through the mouth? And when you try to give them the first spoon, many times I've fed patients, and the tears will just come running through the eyes. It is so thankful. They blessed me so much, because the taste, the smell, the first thing, however long, 6 months, 8 months, 1 year, the peg is there. But when they eat it, the pleasure, the satisfaction, and also the better digestion, because you're chewing and eating, or even at least you're trying to swallow, that really makes makes a better difference, is what this one. So causes of dysphagia in children, there are a lot of things because of prematurity and developmental disability. But let us look at in adults. Old age, neurodegenerative diseases, head and neck cancer is again a big branch where It is very difficult when you have taken a laryngectomy, when there is a resection of the jaw. It is very difficult to manage the bolus in the mouth to swallow. And in both children and adults, there is a lot of neurological and neck and upper esophageal thing. And also definitely in GERD, where they cough a lot, there is burning. And because of several types of acid reflux that come there is a stricture. In the first slide I would have showed you in that title slide, when there is a stricture, even through when people try to self-harm themselves by drinking a corrosive poisoning, there is a stricture, and food pipe is just like a pipe. The food has to go through, and when there is a stricture, it cannot go in, and they keep vomiting. So without food, I'm sure no one can live, and it is very difficult. And there is also pill dysphagia, water dysphagia, where it is very common that they cannot. The most difficult thing for a stroke patient, a neuro patient, to swallow is water. The first thing when we give is never give a water, because they will aspirate. First, we give only a pureed food. In a neuro condition, we never give water. First thing, a few through the teaspoons, which the attender will give without you knowing, and they cough and it becomes aspiration. So definitely never give water for a neuropharyngeal dysphagia. So disease category, prevalence of dysphagia, 70% stroke. There is so much of stroke in young, like you see that there are a lot of MIs and heart attacks that is happening in the young population. There are several papers, even in India and abroad. Stroke in young is very, very high because of the stress and the bad lifestyle, diabetes, obesity, abdominal obesity, visceral fat. So stroke in young is common in India also. 30% traumatic brain injury, which is what happens is the 19, the 20, the 21-year-old. Always it is between the 19 to 23-year-old where they drive rashly in the bikes without helmet. And whenever there is a TBI, more than 50% is between 19 to 23. So definitely you should wear your helmet, and because you are looking at a very bleak future, because the family suffers a lot, and better safety, better to be safe than sorry. So definitely you should not allow the family members not to travel without helmet. 75% neurological disease have dysphagia, and 40% in oncology. Now, ALA, which is all these are neuro conditions. You can see myasthenia gravis, multiple sclerosis, muscular dystrophy, Parkinson's disease, stroke, all these, because these are all, as I said, there are cranial nerves. You saw the number of muscles, the number of cranial roots and the cranial nerves. Brain is such a wonderful organ. No other organ is as important as the brain is, my thing is, because it connects the gut. It gives signals to the gut. It has so many signals. It talks all the time to the hormonal centers in our body. It talks, it commands, it gives so much of signals, and these are the neuro connections which are the most important. And only when you have a neuro disease, you realize as simple as something like swallowing is compromised. Causes of neuropharyngeal dysphagia, there are neurological disorders, structural abnormalities, which is very common, like I said, acid, and there is a stricture or you self-harm, muscular disorders where there are muscular dystrophies, and definitely of the myoneural junction when it happens, the myasthenia gravis, and also the Eaton-Lambert syndrome, which is there. So everything in neuro, many conditions are a progressive disease. So it is very important to assess dysphagia correctly and intervene. Where dietitians come into picture is because of malnutrition and dehydration, and they are unable to eat properly, swallow properly, and when there is a rice tube also, they take very less. So we need to convince the doctors in the rounds, no, he has eaten only a few spoons, it is not adequate. So let the pig tube, let the rice tube be there, let us be there. So even though the nasogastric tube is only for 2 weeks, not more than 2 weeks, if it is more than 2 weeks, the guidelines is to have a peg. But in India, we don't immediately, because the patient is going to have rice tube for more than 2 weeks, immediately in India, they don't do a peg because many attenders don't want that. So what happens is, it is almost 1 month at least when they keep the rice tube. That is why it is like this. So we need to prevent malnutrition. Excuse me. the aspiration, the nasopharyngeal aspiration, dysphonia, abnormal, there is tobacco use, the neurology is compromised, muscles are compromised. There is eosinophilic esophagitis is some things that is very common nowadays. It is also there in young children, and that also causes dysphagia. And you can see there is functional, there is supraesophageal, and many are neuro and onco. Excuse me. Signs of aspiration, you can see there is pain in trouble. It is actually like swallowing a handful of nails for them, because already there is tracheostomy, then in many cases, and then there will be a Riles tube which is 16 French. We are not using like a West where is 8 French, 10, even 12, but it is 16, which is quite thick for them to have it in the throat and then try to swallow a pureed food. So you can see all these signs of aspiration. Now, look at this. This is a validated international assessment for dysphagia for dietitians, Eat 10 protocol. It helps to measure the swallowing difficulties, and you can see that you have to tick whether they have a swallowing problem. What I want to tell you one is, we had a Parkinson's Day a few years ago, and you could see that whenever we did a survey, when we asked the patient, they will say, no, I'm not having any swallowing difficulty now. No, it is okay. No, I'm trying to eat myself and all that. But when you ask the attender, they will say, no, he's coughing a lot, she's coughing a lot and all that. So it's better to talk to them in a nice way to understand the psychology, because people, especially older people, will not agree to have their problem because they don't want to burden their children. That is why they don't drink enough water. We all have enough experience, like when geriatric patients come, they stop drinking water most of the time after 7 because they don't want to go to the loo in the night, and fear of fall, the fear of burdening the children. If they are coughing, they don't tell much. They do some other compensatory strategies. So it is important to talk to the patient and the attender, understand, and then you can try to do to what extent they have these following problems, whether the swallowing is painful, do they cough when they eat, whether the food sticks to the throat, whether they are only liquids alone, it is difficult for them to swallow. All this you have to take it and then mark it accordingly. There is a bedside swallowing test, which is the SLP, the speech language pathologist will do. Few years ago, it was only SLPs, or we call them speech therapists, but there are a lot of specialties nowadays. They are called as swallowing therapist or deglutologist. You know what, there is a deglutology, what a junction. That was one of the conference topic, and it was so catchy when they said deglutology, what a junction, because it is so important how complicated this junction is. Before, it used to be only a neurophysician or an ENT and SLP and a dietitian. Now there is otolaryngologist, and there is a GI physician, because they want to know there is a pipe that is there. There is a speech language pathologist specialized in swallowing therapy, swallowing therapist, and a deglutologist. And you need an ENT because they do the instrumental, and some corporate hospital SLPs are also certified to do that. And definitely you need a clinical dietitian. You need a physiotherapist because the positioning is important. You need a respiratory therapist because when we are trying to feed the ICU patient or the ward patient, I make sure the nurse and the respiratory therapist is there with the suctioning ready, because suddenly they go into severe bouts of cough and it will go into the lungs. So we need to suction it out. So it is such a fascinating branch where you need to know about this. And guidelines for feeding people with dysphagia: you have to sit in an upright position, place food in the strong side of the mouth. So when there is an infarct of the brain on the left side, the right side is compromised. You all know it's the opposite side. So you need to know where the stroke has happened, the infarct has happened, and which is the weak side, and you have to put it on the strong side. The bolus sit at below their eye level. I'll show you some pictures, and you have to make sure that they tilt their head forward rather than backward. So much affects the consistency of the food. You know that Nutrition now is such a $1 billion market. People who come to you, they say gluten-free, lactose-free. I take only, probiotics, prebiotics, and on and on and on. So everything, the content of the food, the fiber, the water content, the starch content, the gluten, how it is chopped, blended, ground, how it is the natural thickness, the viscosity of the food is very, very important. The viscosity is. So even in any dysphagia society, if you see, you need a biomedical engineer who has specialized in rheology. Rheology is the viscosity of the food, how it flows. So when you take a carrot puree, so let's take Diwali is coming. So in Deepavali, you take a Goduma alwa, which is your wheat alwa. You know how it is chewy. And when you pour it or you do it, it's a different consistency. And when you take a honey and how you pour it, it's a different viscosity. So that much is very important, the way you swallow. Dry heat makes the food hard. Think of bread toast. So if you dry heat, if you put it in the tawa or on a toaster, it makes it quite hard and crispy. Steaming makes the food soft. Yes, and while frying makes the food crispy. Excuse me. Cold temperature, hot food. Everybody loves hot food. The softness, the temperature has such an important factor in the way the patient swallows the food. Why do you need an interprofessional collaboration? What is the dietitian's role? So there is a physiotherapist, there is an occupational or a respiratory therapist. Definitely nurse is the most important, SLP and the dietitian. What does a dietitian do? First, we need to assess in the sense that we don't say that they have a swallowing difficulty. It is the SLPs who do a bedside swallowing test, or if it is instrumental swallowing, the ENT does that, and they give a swallowing report like an endoscopy swallowing, which is called as FEES. In that, the SLP will write what consistency of food can be given to that patient. We have to assess the nutritional status, interpret SLP's notes, and monitor. Excuse me. Some roles, yes, it overlaps. We need to have a shared skill. We have to complement each other, the SLP, the nurse, and the dietitian, and the physiotherapist. Consider all the medical diagnosis. There will be a patient who's old and would have come with Parkinson's, but he must have been on tube feeding for some time. But there would have been multiple infarcts where there is recurring stroke over the years. That also needs to be considered. So a thorough reading of the clinical history is very, very important. He or she should be considered in total, decide on tube feeds or appropriate nutritional supplement. Very important to understand from the caregiver, history and the onset of presenting difficulties, individual, the carer's perceptions because they live with them 24/7, concerns, priorities, potential risk and difficulties for the individual and the carer, dietary preferences, definitely because food is something very, very personal, eating, drinking and swallowing history, cultural awareness. It is so, so important because India is a very diverse country and we need to understand this. Religious consideration and food allergies. Causes of malnutrition is very common in dysphagia. Danger of not blending to a safe consistency. First thing, our aim is 2 words, safe, swallow, which is what SLP and the dietitian and the nurse is trying to do it for the patient. Safe, swallow. It cannot be, see, when you look at a glob and suppose a Parkinson patient who's also not in hospital, but he's trying to eat at home. It is messy and dissatisfying. He's very embarrassed. They stop going outside. They don't take food in a wedding or in a buffet. They refuse and then slowly they withdraw. They're very embarrassed to have a spoon that is taken because their hands are shaking. The levodopa would have worn off and there is so much of embarrassment for the patient. So when he takes a cup and tries to drink it, it just shakes and then it just drools everywhere and he makes a messy thing and it is very embarrassing and they stop eating in front of others. Reduce nutritional content because everything is ground and it's a blob. Time-consuming food preparation. The carers also over the years they are also so much burden, reduce choice, patient lose their desire to eat and avoid meal times altogether. So look at this. So suppose you have a patient with dysphagia in your ward, just like a liver patient with a cirrhosis waiting for a transplant or a kidney. You say nutritional adequacy calculator. You calculate what the patient has eaten before the morning rounds of the consultant, so that they know, okay, is it adequate or not? And you can tell the consultant, the past 3 days he has eaten only this much protein, this much calorie, is not put a rice tube. You can say that to your neuro, to your any of your condition, but you need to have data. So nutritional adequacy, last 2 days, last 3 days, this is what is happening, and he's not having it. So because as such, neuro will be go into catabolism very, very, very fast, and they lose their muscle and fat very fast. They become skin and bones and emaciated just within days. How do you increase nutrient density? You can add ONS, or you can add many seed powders, but it all depends upon the consistency of the food. So how do you increase? They will eat only that 5 spoons. You have to add ONS. You can add whey protein isolate. You can add sweet potatoes boiled and mashed, skim milk powder. You can add date syrup because they like it. Jackfruit flour, that is also like a resistant starch and it goes very well. Yes, many of you do arrowroot flour and other things, but these are a little bit more nutritious. So that is why it is important that you stick to the consistency which the SLP has advised, because they know whether the vocal cord is palsied, whether there is vocal cord paralysis, whether the patient is a laryngectomy patient, everything, the anatomy. You have to read the FEES report or the SLP's report to know what is palsied, what is paralyzed, why is he not able to swallow. Depending on that, you will know what is the consistency you need to give. Risk factors for dehydration, there is aging and there is disease. They are a pill dysphagia because they cannot swallow a pill, they cannot drink liquids. Dehydration is very, very common. That is why just for water, like Meenakshi mentioned, either in PEG is placed or many times Ryle's tube is always there when the patient goes home. Many times is because they cannot swallow water. Fluid and electrolyte requirements should be met via oral or enteral routes as far as possible, because you need to make sure that drink, you cannot say if he's coughing, if he or she is coughing. First measure is to replace fluid loss. There are thickeners available now. Now I want to see that you have to be at the eye level of the patient. I know many of us don't do, but you have to be very careful. You need to have a respiratory therapist next to you or a nurse with a suction. The nurse can do it. You can teach the nurse in a nurse training program, and then that has to be there. So when you sit at a eye level with the patient, they really like it, and you're communicating them, reassuring them that yes, you have time to help. It is a bolus. How is it? How is it tasting? Is it warm? They really like that, and they are so thankful when you try to give them that first feed of pureed food. Coughing, choking, look at the wet, gurgly voice, taking a long time. They would love to have that taste, but they don't know how to swallow. So just like a kid, a toddler, they'll keep it on the left side, they'll keep it on the right side, but they are so scared to do it. So many exercises will be taught before by the SLP, complaining of difficulty, reluctance to eat certain consistencies because they are scared. So if they see that there is somebody holding a suction tube, they are ready to do it, and then you can suction it out. Otherwise, the bouts of coughing is so bad that they will aspirate. Feeling of food getting stuck in the mouth, holding food in the cheeks, and food or drink falling out of the mouth because they are not able to take the bolus, the pureed food from the front of the mouth to the back of it, to the throat to swallow. Best practices, work together as a multidisciplinary team, communicate changes. Just like you have a very good rapport with your physiotherapist for a Ryle's tube. So I'm sure all clinical dietitians here would say that physiotherapist, you'll know that you would have told the sister that these are the timings for the feeds. Every 2 hours, the physiotherapist can come in between and not stop the feeding just because the physiotherapy is happening. I'm sure you have a good rapport where the bottom line is patient safety and patient care, and of course, prevention of malnutrition. Patients with dysphagia are at increased nutritional risk. You have to consider food fortification, ensuring choice of suitable snacks and nourishing drinks. Theory versus setting. Look at this. I think you should be more explicit here in step 2. So you can't just think that a pureed food, the person, the nurse should understand what is a pureed food. Your dietary department, your food server, your food handlers, your chef should understand dysphagia diet. And you say, example, pureed food when I call from the ward or the ICU. When I say the pureed food, carrot puree, how it should come. And when you say it is a thick rice kanji or a ragi kanji, how it should come. So these are already trained. We have dysphagia diets in our hospital. And when we say certain terms, they know what type to give. Otherwise, what happens is what you order and what you get would be completely different. So geriatric malnutrition and also stroke in young, especially if dysphagia, it's not sufficiently and carefully screened. That is why dysphagia is called as hidden disability. Rehabilitation is very important. World Swallowing Day is in December. World Swallowing Week is from December 11th to December 16th all over the world. And December 12th is World Swallowing Day. What is a dietitian's responsibility? Develop a screening tool, training protocols, nutrition and swallowing checklist, take a key role in the treatment of dysphagia, improve the quality of life, shorten healing times, reduce length of stay, widely prevalent in many disciplines, including post-COVID, and it plays a very important role in rehabilitation because there is a lot of, in corporate hospitals or in primary, there is a lot of rehabilitative medicine is now available. I was very thankful that the International Dysphagia Research Society started including nutrition only from last few months. All these times it was only their academicians and their speech language pathologists always doing their thing. And nutrition was never included. Nutrition was first time included a few months ago as part of their curriculum campaign and how this discipline should be there. Without that, it doesn't get completed. So they wanted to train nutritionists all over the world regarding this, and I had applied, and I was very, very thankful that I was the only nutritionist selected from all over the world, and many were selected only in the US, and I was the only one internationally selected. I was very thankful. And these are all the faculties who was, pioneer in dysphagia. This is the DRS president, who's a biomedical engineer who has done so much on rheology of foods. And this is the ABA, one of the thing who deals with nutrition, and she heads in West Coast, Central West Coast, where it is, she heads the nutrition, and she had given a talk on the importance of nutrition in dysphagia. So I'm going to stop share. Do I have a few minutes left to talk about interdisciplinary management?
Yeah, sure, Srimati.
I'll quickly finish it. I just want to know the role of thickeners and how the consistency of the diet should be. So, am I able to share this? Are you seeing my screen?
Not yet.
Is it there?
Not yet.
Okay, so let me stop sharing. Share screen. Is it there?
Yeah, very much. Yeah. You'll have to just make it full screen.
Sure. Yeah? Yeah.
Yeah, good to go.
Thank you. Role of textured diets. There are many papers which says that textured diets is a safe compensatory strategy for the people suffering from dysphagia, and thickeners are there to thicken the water or any other consistency that is very important to do this. So it is very difficult to swallow when there is a tube or without a tube because of muscle impairment. And dehydration impacts. This is one of my 19-year-old traumatic brain injury. He was admitted to the hospital just 2 days before the COVID. He had gone in a bike, and he was in UP, and 2 days before the shutdown happened for the first COVID wave. So you can imagine how much trauma the family would have faced. So he was just skin and bones. He lost 35 kilos in the first week in the ICU because it was a traumatic brain injury, and immediately COVID came, and the whole nation was in a shutdown, and too much of patients in the ICUs, and chaos, as you all can recall. And so he lost 35 kilos, and proper nutrition was not there. And somehow they found me through a Facebook neuronutrition group, which I was not aware that existed. Now I'm not. So someone else told me that I specialize in that, and they somehow found my number and they called me from UP. And only when he was discharged from hospital, like I cannot manage like when someone else is managing in the hospital, though I gave them guidance and they were okay with it after asking the chief dietitian of that hospital. But once they went in, he had peg failure 3 times because it was such a chaos in the hospital. It was very difficult for them to do the peg that time, and 3 times it failed. And then I told them, they came home with an NJ, and I was very clear. I told the mother, please insist on peg tube. He's very young. We cannot feed him for months because it's going to take months and months for him to rehabilitate. And I want peg placed. And she went again to Delhi, got it transferred, and then placed the peg. Still now, whenever she talks to me, he's now completely all right. He's 21 now. And when first time, I have a video, I didn't share it here, but when I gave that pureed food through telemedicine, that is how I used to talk to them. He used to argue with me, ma'am, give me Maggie. Don't give me this papaya puree. Give me Maggie. Now he's come better, much better, though, and he's trying to back to enroll in classes. And this is so important is because malnutrition, if you don't address it that time and then walk them through the dysphagia, through their traumatic brain injury, it becomes very, very difficult. He had multiple bed sores. He was just skin and bones. His eyes were sunken. I don't want to show those snaps. And aspiration and so many problems he had, and it took almost 2 years. So we play a very, very important role in rehabilitation of the patient. This is also his hands, and he didn't look like 19. It was very difficult for him to even tolerate those peg tube feeds, and how it took more than a year to first make him come back to certain normalcy and then try to do that through the mouth. To maintain and ensure adequate nutrition is our responsibility. Early detection of dysphagia along with the SLP, and how you handhold the patient and the caregiver. So the thin and the thick water, thin water, thick water, nectar-like, honey-like, spoon-thick, all this is there. And the viscosity of that, we were thinking that nutrition is food science, food chemistry, biochemistry, so many things come into picture. Biomedical is very, very important here, where rheology, the viscosity of the liquids, which is done there through centipoise, which is a CP, and this is how they measure that. Each food. So viscosity is only a number of relevant parameters affecting the liquid flow, and that includes the density, the yield stress, the temperature, the elasticity, the propulsion. So much is there in just a food, and it affects how much they can swallow. Drinks thickened with different thickening agents, naturally thick, will have different flowing character. Imagine, for example, you order a rice kanji or a rava kanji. By the time it comes to the ward after 10 or 15 minutes, or to the ICU in that AC or in the ward, the consistency of that rice kanji is completely different because it is cold. The doctor would have come for rounds. By the time the nurse comes and she's free and she's trying to give that, it will be in a gel. But you would have ordered a nectar-like thing. But when it comes here, it is in a gel. So that flow characteristics in practice is completely different, and you need to sensitize the nurses. The nature of the thickened drinks makes them impossible to characterize with only one viscosity measurement. So we need to talk the same language as interdisciplinary people, saying that, okay, you understand this. So I had an example. There was a neurologist just last week for a myasthenia gravis patient, and she said, no, you have to give a khichdi. And I said, no, I'm giving a puree. She said, no, khichdi soft and running. I said, how can it be soft and also running? It can't be both. And then I told her, I showed certain snaps in my phone because I always have dysphagia pics in my phone. And when I showed her, she said, yeah, this is the one I want. I said, that is why this is called puree. It is not thick and thin and running. It's not like that. It holds its shape, and this is called as puree. So many things are there. You need to be confident. You need to know what is happening in this field to talk and convince, because bottom line, everyone wants the patient to recover, eat well, and go home. So why standardization? We need to understand the texture and the drink, the thickness level for an adult, a pediatric. We need to have detailed definitions, especially in India. So when you call for a carrot puree, this is what it comes. Can you imagine a patient any patient with dysphagia trying to swallow this? Will he bite and chew the solid, or is he going to swallow the liquid? It is double consistency here. So it comes as a lumpy puree. So you need to train your food and beverage very, very clearly how the pureed food should be, and not with multiple consistencies. That is it should be like this. These are all my original snaps. So that also came to the ward like this, and my F&B had a earful that day. So this is papaya puree for dysphagia. It should be so well, and when you take it, it's just like a thin alva, and it just goes very so easily, and they are so happy to have that little bit of sweet in their mouth. So texture has to be correctly defined. Any food that can be defined by textural characteristic, more than 24 food textures have been identified. However, only 8 of these textures are considered most significant in treating dysphagia. So you be aware, you prepare, and you adapt. So the ITSI system is the International Dysphagia Diet standard initiative that is followed internationally. How you communicate. I did all their courses and certified myself, but to an Indian setting, it is a little bit difficult because what they say with their food. So we have to try to standardize Indian diets. That is one of my goal with all of you out there, east, west, north, south. We need to do something for our Indian guidelines. This is the ITSI framework, and this is how they do it. How so? When you try, this is a special syringe which I have. So when ordered specially, because this is a special syringe where it goes through that, and you can see that each one, if it is level 0, how it flows through the syringe. There is between 1 and 4 ml, how much is remaining. This all dietary won't do. And we can't say, okay, when you say a rice kanji, they will put 2 spoons one day. Somebody is so mad, the chef, and he'll put one day, just throw something one and then do it. So you might think it is level 1 and it will come as level 3. So in an Indian setting, we need to understand them and then try to do something to standardize our Indian diets. This is the ITSI flow test. Can you see the first one, how fast it is pouring, that they cannot swallow in certain conditions. And the third one, see how it is doing. So that is level 3. So if this many ml is remaining, accordingly, they characterize what liquid it is. So this is how it is a standardization initiative. The same grade 4, so thicker to thinner, grade 1 to thicker is grade 4 to thinner, both vice versa, and how it is. Each product has to be done by the syringe test, and it is done. So there is a fork test where when you smash it in the bread, a soft bread, how it is, and how they do it with that same level. They are trying to do it in the pressure, and they are trying to do it. It is all very difficult in our Indian diet because the khichdi, the pongal, the masala khichdi. So that is why I say culturally we need to know how a khichdi is prepared in Gujarat, how a masala khichdi is prepared in Delhi, how a pongal is prepared in Tamil Nadu, how in red rice a khichdi might be prepared in Karnataka, Telugu, they will have a different thing. So we need to be completely culturally aware when you are talking to the patient. I'm sure that many of you with so many experienced people out here, when you try to talk in their own native language, they connect with you like this because they think that when you talk in their language, they understand their food. That is given. So the most important thing I think in a dietitian counseling is to speak several languages and to communicate in their level and also convince them and try to talk in a very caring, empathetic manner. New tools of the trade. So I told you about the different that is remaining. These are all my snaps. So the thick rice kheer, how it should be. The apple, this is a apple pudding which is boiled in the pressure cooker. The skin is removed and then it is pureed. You can add honey, you can add date syrup. The thickener, the consistency is different, thick vegetable soup. So this is for a different patient where they need to do first the liquid. This is multiple consistencies. They will not be able to swallow, but this khichdi is okay. But the jeera should not be as jeera, but it should be as a jeera powder. So nutrient dense, make every safe swallow count, add the calories, add the protein, add the micronutrient, add the fiber, understand the texture. You will be, if you look at a food, when a food industry is trying to launch a particular food, what is the most important? They look at not the smell or the taste, but it is the texture. When I say Magdi's French fries, when I say K.C. Das Rasagulla, when I say Tirunelveli Halwa, each one has a different biting consistency, and that is the thing, the chewability, the biteability, the firmness, the hardness, the springiness, the viscosity, which is for liquids, the shear, the adhesiveness, how it sticks to your throat or your tongue or your upper jaw, cohesiveness, all this matters. And food texture is the most important thing. That can you imagine a French fry when you order, when it comes and it is all limp? You will hate it. It has to be crisp on the outside and soft on the inside and hot. And when you put your salt and pepper, it tastes divine. Teamwork, very important. And the interdisciplinary team makes up very important. So you need to be as close to your SLPs, just like you do with your physiotherapist. Training, nursing, and caregiving is very important. Understand the different way you call that food and understand the food and beverage, also understand the same language. Principles of thickening. Thickeners are used in many, many ways. A gel, a pectin, a starch, a guar gum are all used. And instant food and beverage thickeners are available. Xanthan gum, guar gum. Guar gum is from Kotavaranga, which is our cluster beans, cornstarch, tapioca starch, and arrowroot. And this is what I was talking yesterday, that in one sheet, everything is there. How is the positioning of the patient? What is the diet that you're giving? Well, you can also help me stave. What is my drink that is recommended, approved by the dietitian and the SLP? What is the texture? See, so what I can do, there should be no lumps. My food cannot have any chewing. How they have equipment, what is necessary for the patient when they go home. This is also excellent. On discharge, they are given like this. That is seen by the dietitian, the SLP, and the physio, because what you have written, the SLP will see, or what the SLP has written, the dietitian will see. The physio will also understand and talk to the patient that the patient has to be in this position when you're giving, or at least 45 degrees if he is bedridden. So during the COVID, just 6 months before the COVID, I had an ESSD. I developed my own thickener a few months before COVID. That is because there was someone very senior who called me on the phone and said, Srimati, we should have our own thickener. We cannot import it. It costs 3,000 plus. And I see so many kids and adults, because he was a part of in the government and also very well respected in international and national societies, because he's in the disability forum. And he said 3,000 rupees an Indian patient cannot afford just for one thickener. Please do something. So when I did it, I spoke to a CFTRI scientist, an ex-scientist, and I came up with a thickener. And now it is not in production, but I tested it in different hospital. Sadly, after the COVID, the factory was closed. But this is what is.
Hello, everyone.
And I was selected for the.
Thanks. This is 10th ESSD.
So the main thing what I want to tell you is I had trained the FNB. This is the thickener was used. It was tapioca starch, medical grade, because the food scientist explained to me that the tapioca starch is usually used as a starch for the cloth in dobies and other things. So we cannot do it. We have to use medical grade tapioca starch if you have to do a thickener. And we tried it in many consistencies. As a nutritionist, I made sure there was, because constipation is very common in neuro patients, I made sure there was prebiotic fiber, some trace minerals. I had added some vitamins. And when I put it in the ESSD, they were very happy because the cost of that thickener, imported was 3,200 something, and mine was less than 500 rupees.
Hello, everyone.
Barriers are numerous, and we as dietitians are very, very, we need to know that what is the problem at home when they do the food, what is the logistics at home, because they go into catabolism, the wound, the grade 1, 2, 3, 4, they come with such ulcers, pressure ulcers. So it is because they are long-term bedridden patients, and or immobility is very common, or a progressive neuro disease. So we need to have innovation. We need to understand, build relationship and communication. Training the nursing personnel is very, very important. Interdisciplinary team, just like a liver transplant, we have interdisciplinary meeting before the transplant, before they make the patients in 1, 2, 3, 4, 5, like that. They will know, you will tell them, no, he had a recent infection, he's on tube. So many things you can give it. The physiotherapist will say something, the nursing will say something, the other doctors, multidisciplinary doctors will say. So you need to have an interdisciplinary dysphagia team. Indian data, we need to work on individual groups according to north, east, west, south, because our food is completely diverse. I need all your help, and we all need to work together to come with some Indian standardization. This is a dysphagia core group where awareness, we did it in 26 languages that they need to screen for dysphagia. The last year, World Swallowing Week for December. And from IAPN, we did about 26 languages where they said, you have a geriatric thing at home, please screen for dysphagia. It is there in the website. And food experience for dysphagia is very, very important. In the West, they have 3D, and they have, so not every disability is visible. Dysphagia awareness is a hidden disability, and we need to sensitize us, educate ourselves first, and also educate the caregiver. Thank you so much for patience listening. Sorry if I rambled too much, and thank you so much, IDA, Chennai chapter, and all the listeners. Thank you.
Thank you so much, Sri. I think it was wonderful. We did not even realize where that 1 hour flew away. I think your emotion and passion with the excellence in trying to prevent malnutrition, and I really felt the emotion moving down. So unless you're emotional about your profession, you wouldn't take it up as passionate as you have done it. I think the few years or more than 2 decades which you have spent with your patients was quite evident in this little presentation, though I think lots more. We give you a few more hours and still there'll be lots of learning. And I would request the questions to be taken up a little later, because we have already requested Dr. Madhumita to be with us at this particular time. If it's okay with you, can we take your questions a little later?
Sure, no problem.
Oh, thank you so much, Sri. So can we have Dr. Madhumita's CV? Rajeshwari, can you please take it through?
Yes. We will go on to the next session with the incredible benefits, safety, and efficacy of ashwagandha and Brahmi by Dr. Madhumita Krishnan, consultant Ayurveda pediatrician and childbirth educator. Chairperson for the session will be Mr. P. Krishnamurthy, and moderator for the session will be Mrs. Sheila Krishnaswamy. Krishnamurthy sir, being convener of Indian Dietetic Association, I would like to introduce Mrs. Sheila Krishnaswamy, a renowned diet, nutrition and wellness consultant and ex-president of Indian Dietetic Association with 4 decades of professional experience in the clinical, corporate, and communication spaces pan-India. Pioneered nutrition consulting in corporate companies and actively involved in national and international dietetic associations and has been in the mainstream media for the past 27 years, and also an entrepreneur, editor, and public speaker, and a blogger, and currently a nutrition and wellness consultant, and works independently as an advisor, writer, and anchor as a corporate trainer. Over to you, ma'am, to open this session.
Thank you so much. Can you change the slide, please? Who was monitoring the slide? Thank you. Yeah, thank you so much for inviting me to moderate Madhu's session. Thank you both to Good Monk and IDA Chennai chapter. It's a great pleasure to introduce Dr. Madhumita Krishnan to all of you. She's a consultant in Ayurveda and she's specialized in pediatrics. She's a pediatrician childbirth educator. She has a passion for Ayurveda with a special interest in management of children with cerebral palsy and special children. She's given various talks on principles of Ayurveda. She's written articles. She runs a course in association with TDU called Introduction to Ayurveda Dietetics. And I think a lot of IDA members have attended this course. The list of articles are quite long, as you can see. She's also done some online videos on Facebook and YouTube. And recently, I think she's gotten onto Instagram also to start, sharing some information on Instagram. And of course, I think most of you already know that she's the sweet daughter of our former national president, Dr. Dharani Krishnan, who also belongs to Chennai chapter. Over to you, Madhu.
Good evening, everyone. Thank you so much. I think when I'm introduced as my mother's daughter, it becomes quite heavy, but no doubt I am her daughter, no doubt about that. So having said that, at the outset, let me thank IDA chapter, Chennai chapter, for giving me this wonderful opportunity with Good Monk to talk about this topic, which is benefits, safety, and efficacy of Brahmi and Ashwagandha. So before we go into our stars of today's topic, I would like to take a step back and talk about why this topic is probably in the forefront of today. So most cases as a practitioner, one of the major concerns which I come across is where I find the line very blurry between food and functional foods and medicine, where I have people coming to me saying that when we take Ayurveda, we know it has no side effects, which is why we want to take that, etc. And in the same stream, nowadays, we have lots of people and papers which have come out talking about how the use of ashwagandha or even turmeric for that matter has led to lead poisoning or liver disorders, etc. So this led me to think, and especially in COVID, a big backlash which came about was about the guduchi, or what we call as amritabali, the tinospora, which they said was leading to liver failure, kidney disorders, etc. So this got me thinking there is something which is missing here. First and foremost, we need to differentiate between what we call as food and what we call as medicine. And that's exactly what I wanted to define first, where we are differentiating what we call as food or ahara in Ayurveda and what we call medicine or aushadha in Ayurveda. So there are certain different points which come into play, where for food, we would say, yes, that's that which provides nourishment, which satisfies the mind, which is considered to be food, etc. Like the basic explanation which is given in this regard of food, it says it not only nourishes the body, but it's very, very important that it also nourishes and satisfies the mind. And the methodology of description of these foods is more experiential. It is not in the sense of what we understand today or what all of you would be familiar with in terms of the carbohydrate content, the protein content, the calorific requirements, etc., but slightly different where it says when we put this food into our mouth, how is it that our body reacts or experiences it? Is it something which is dominant in the sweet taste? Is it something which causes a dryness in the body? Is it something which you feel heavy after consuming, etc.? So in that sense, the most important property which is given to defining food is the rasa or the taste, right? Then it also mentions in Ayurveda that food in general is something which can be had in larger quantities. And that is true. The quantity of, just to say in a slightly different manner, nowadays people do tend to have a lot of medications also. And I see in my pediatric practice, when children come and they're on so many medications, I tell them, you seem to be having more medicines than food. But ideally, we should be having more food in larger quantities because that's what is giving us nourishment in a sense. And of course, this is something which should be had on a daily basis. So then the differentiation comes with the aushadha or the medicine, which is the exact opposite, where the first and foremost definition which is given is that something that treats, alleviates, or prevents symptoms of the disease. And that's exactly why a person would opt to go for a specific medication or not. And then most importantly, the property which is considered here, which makes it different from food, is what it's called is its inherent potency. And this in general, nowadays, we were talking about temperature as such, that is hot versus cold, but this goes in a slightly deeper sense of how the body reacts to it. In the sense that when you have something like a chili or a pepper, you experience that heat from within. It's just not in the tip of the tongue or, something which you can touch and feel. Or something like a coconut water, when you drink, you feel that cooling effect from within, right? So that kind of hot and cold is what is described as the potency, and generally medicines are derived or explained in that sense. And as such, the definition of medication in Ayurveda says that which has to be used in an extremely small quantity. When it is had in a small quantity, and that should be sufficient to alleviate, prevent, and treat the conditions which we are talking about. And most commonly, these are considered to be used for a short period of time, not something which you constantly have, but as long as you have the disease and the imbalance is there, you have these medications, and once it is settled, you stop it. Did this make my job easier? Not at all. Because then I have a set of people who say, I have heard that I can take tulsi on a daily basis, and this will not have any negative effect. But I know that if I use it, it's good for my respiratory system, but I am experiencing something different. Similarly, household like names have become medicines such as ashwagandha, shatavari, etc. Especially post-COVID, I would say these have become very popular because everyone is talking about them as functional foods or functional medicines which can be had on a daily basis. So then again, I went back to the classics to understand why is it that there are certain medications? Because even in my practice, there are certain medications I need to use for a long period of time. And in the definition of a medicine, that completely negates it. Similarly, there are certain properties which I said due to which it cannot be used continuously. So then when I went back to the classics, the answer was right there. And this is what is called a rasayana, or something which is rejuvenating in nature. So this is a very, very famous quote, which probably you may have heard as doctors, dietitians, etc., which is to say, longevity is a vascular question. It's as simple as that. If each and every cell in our body has the capability of receiving that nourishment which we are eating through the vessels which are present all over our body, then that itself is sufficient to keep that cell going. The minute that nourishment becomes less or is affected, then that cell is not going to be able to function. It's as simple as that. So in Ayurveda, we clearly understand this and say at certain times, due to age, due to certain activities which we do, etc., the vessels in our body get affected, and this flow of nutrients which we require also gets affected. And that's where these rasayanas, or where you can see the definition of this word as the essence of the metabolized food reaching each and every channel. And that's the reason why these rasayanas have been explained. And it has a source from both foods, like for example, certain things such as milk come under this rasayana category, and you have certain medications which also come under this category. So what do? They have the ability of nourishing each and every cell in the body to keep it healthy. And how does it get to that? So it has a threefold effect. The first and foremost is to improve the circulation of these cells. And that is called, it's as simple as if the channel is blocked, the nourishment is not going to be able to flow through it. So the first and foremost is to open that channel, which is what this is capable of doing. Second is to ensure that the assimilation of the nutrient which we are having is occurring through these channels, and in the long process, improving nourishment to each and every cell. So then the question comes, when should we start this? And it is pretty interesting to see, like we all know, when we are in the geriatric age group, naturally our processes slow down, our nourishment reduces, etc. But here they say right from birth, there are certain rasayanas which need to be given. And why is that? To ensure that the child is able to grow to its maximum potential. Similarly, in childhood, the reason in middle age becomes slightly different. Here they say it's not for growth. It's not for you to gain your maximum potential, but because at this stage, the degeneration of the body begins, the closing of these channels begin. You need to have these nutrients or these rasayanas to ensure that that flow continues and all the cells get their proper nourishment. So now that we have seen that, yes, there are certain medications which a person can have on a daily basis, this answered my question and query as to how safe it is to use these medications on a daily basis, right? So let's now talk about our two stars of today, which is Brahmi and Ashwagandha. Let's first start with Brahmi. So Brahmi, there are two Latin names for this. The most commonly identified one is the Bocarpa munieri, or what you can see on the left side of my screen. You also have what is called the Centella asiatica, which is also used as Brahmi. Interestingly, more or less the properties of both of these are similar or the same. As I said, the properties which are explained in this form are not important in the calorific, etc. sense, but we describe it in the sense of how the body experiences or utilizes it, which is where the taste, as we said, is considered to be bitter and astringent. It is generally light on digestion. It has that cooling thermal property, which generally is associated with rasayanas. It has a sweet post-digestive taste, which would mean that it helps in nourishing each and every tissue. And because we understand the physiology of the body through these physiological functions, which we term as Vata, Pitta, Kapha, the terminology is not important, but basically something which helps in balancing or imbalancing these doshas is what we go for when we go to understand the disease progression, etc. Right? And these basically balance what we understand as Vata and Pitta, which generally has to do with more catabolism, degeneration, loss of flow of nourishment, etc. within our body. So what are the benefits which come with Brahmi? It improves intellect, which is why traditionally many states in India itself, particularly if you go to the Konkan side, they use this in the form of a chutney, or they put it in buttermilk, which they have. And they know that this is something which relieves stress, it improves the intellect, and can be given across age groups. So there you can see it improves memory. It is considered to be anti-inflammatory, as we were talking about vascularity and longevity being a vascular question. We need to prevent anything that's going to cause the blockage of the channels. And inflammation is one of them. So anti-inflammatory, it improves digestion, which is important for the assimilation. It improves the quality of life. Anti-aging, which is what we're all looking for, to remain as young as possible for as long as possible. It is very effective in psychiatric disorders. It improves speech. It improves cardiac health. It can be useful in spleen disorders as well as diabetes. And it also overall helps in improving strength. So in my practice as such, when I look at it, I have not really seen, I would not say that there have not been cases where Brahmi has not suited people. We will be talking about a few complications which occur when a person has too much of Brahmi. But I also thought, let me go to the research papers and understand if there has been something done in this regard. And there has been a study which has been done by the CDRI, and they have actually developed a product post this to see the safety of using Brahmi over a long period of time. So they did it both in rodent as well as non-rodent models of Brahmi extract, and they found that it was safe as well as efficacious. Sorry for the busy slide, but I just wanted to show you that this has been done in a specific methodology. And only the red part I just wanted to highlight to show you what the results were, right? So they were able to find out, as similar to what Ayurveda has explained, that these bacosides help in protein synthesis, which helps in memory formation, etc. And they've also found that it is very well tolerated, efficacious, and does not have any side effects. And it can be even used in children with special needs such as ADHD, autism, etc. And they have found that there has been significant improvement. Even in my own practice, I have found that this has found to be very, very effective in such conditions. And as you can see, they have made a licensed product based on this Brahmi now. Now, as I said, there are a few complications which I've seen in practice which can come if you have excess of this. And this includes things such as dizziness, nausea, skin rashes, drowsiness, confusion, headache, diarrhea, etc. But let me tell you, this is not very common. Most people tolerate Brahmi very, very well. But of course, if it is given in an excess dose, if there is some problem with regards to that, when the person is not able to handle it, then in such cases, these complications are possible. But it is minimal as compared to others. Now, let's also talk about ashwagandha. Similarly, the taste which is explained here is that it is pungent, bitter, and astringent. This is oily in nature, but it is light on digestion. This has a hot potency. It is pungent. And the most important thing to highlight here is that it balances all the three doshas. So this is something, the Withania somnifera, which is the Latin name of this herb, is an excellent one when it comes to balancing all the three doshas and maintaining the physiological processes within our body. So the benefits, again, when we see them, it improves strength. This is known for that. Again, this is something which is given right from childhood, because that's the time they really need to improve the growth, maximize the growth potential in the child. Immunity, I think this is why after COVID, this has been given a lot of importance. There is actually a study which is being done across the UK to understand the effect of post-rehabilitation and using ashwagandha in that post-COVID. And of course, it improves life expectancy, anti-aging, again, very useful in neurological conditions as it balances all the three doshas. It acts as an aphrodisiac, anti-inflammatory again. It is excessively used in people who have muscle wasting, weakness, etc., due to disease or just due to body structure. Insomnia, very, very effective in promoting sleep. Actually, in the Latin name, the somnifera, which is there, indicates that it can help better sleep or induce sleep in an individual. It is also useful in chronic respiratory issues, promotes wound healing, very effective in skin conditions as well as psychiatric conditions. So here again, I came across two papers to understand the efficacy as well as the safety of ashwagandha. One was done in rodent models, and what they found is that the gradual weight gain, which is the major, property which is given to ashwagandha, they found that that was definitely there. And they have clearly said that there was no signs of intoxication, no changes in blood biochemistry, which were observed. So they found that even in like 5 times the recommended human dose given in a rodent or a rat model, they did not find any kind of different or side effect in the rodent. And similarly, this was done in healthy volunteers, in humans, and there again, they statistically did not find any change or abnormality within different thyroid profiles, the hematological studies which they had done, and there were no adverse events which were reported by the participants. So they could conclude that even up to 8 weeks, which was not a long period of time according to them, it is safe both in males as well as females. But they do add that doing a long-term study, which is like for years, would be preferable. So I would like to conclude that yes, medicines can be used on a daily basis, but there are a few things which we need to keep in mind before choosing the medicine which we use in our body, right? First and foremost, proper identification is very, very important, because like, for example, just to show you 2 pictures, this one is the common betel leaf which we all consume, right? While this, which looks very, very similar to it, is what is called the pippali leaf. And these are 2 completely different things. If you're going to eat the pepper leaf, it's not going to have the effect of the betel leaf. So it's important to properly identify the herb before consumption. And in the case of the Tinospora, which I was telling you, in COVID, they had utilized the wrong type of species. And that is why probably they had those complications which they saw in the individuals. Second, very, very important, the part which is used. Each medicinal plant has a specific part which is very high in, the effect which it has. If we use the wrong parts, then that could also lead to complications. Like, for example, even in food, if you were to have a carrot or a beetroot, yes, you have the leaves, but majorly, that you need to have the roots in this case. Similarly, the mint leaves are well known. And if you want to have mint, you're not going to go for the roots or the stem, but rather the leaves itself. And similarly, the blue pea flower, which we have, you're going to use the flower and not the leaves. And the jeera, the cumin seeds, are going to be effective if you use the seeds and not the roots or the stem. So what I'm trying to say is the part used is very, very important in the herb which we are using. And finally, the dose. Now, why is it that people are experiencing lead poisoning by having turmeric, which is something which is very integral in our Indian diet? There's a huge difference between having a 1/4 teaspoon or a pinch of turmeric versus whole of 1/2 cup of turmeric. Yes, turmeric is part of my food, but that does not mean that I overindulge and have like 5 teaspoons. I am going to have a negative effect of that, right? So these are 3 things which we definitely need to keep in mind while thinking about a herb: the proper identification, the part used, and the dose. And I would like to end with a very, very famous but very important quote, which says that when yatha visham yatha shastram yatha agni shaniryatha. Sorry, just indulge me for a moment. Tata aushadam vijnatam amritam yata. All it says is that in the dosing and your understanding the difference of nectar versus poison, as in a poison in the right dose, in the right individual, can become nectar if used properly. And even nectar, if you use excessively and in the wrong dose, can lead to become like a poison in an individual. With that, I will end. Thank you for this wonderful opportunity. And I think we will start with the questions.
Thank you so much, Madhu. That was a brief but beautiful presentation. And I think all of us, the interest that we all have in Ayurveda, and especially because Ayurveda and dietetics are kind of merging together nowadays, we could just go on and on. There's so much to learn in this field, but you made it very brief and beautiful. Thank you so much once again for sparing your time and being with us today. Meenakshi, would you like to take the coordinate?
Yeah, ma'am. We would like to take a few questions. There are a few questions in the chat box.
Yeah.
Yeah, ma'am, would you, can you see the questions at the chat box?
Yes, I can.
Okay, ma'am.
So there's one question for Srimati. Srimati, are you here?
Yes, ma'am.
Okay. There's a question to you. It says, which key micronutrient deficiencies are observed in patients with dysphagia?
So it is not like we are seeing so many different conditions, both neuro and head and neck cancer. So we cannot say that in dysphagia you'll have a deficiency. It is like saying what type of deficiency will you have in a cancer? Because there is umbrella of things. So we cannot just say dysphagia you'll have it. One of the common problems which I can say is a constipation, because they are not chewing and swallowing and things like that, but not as such as a deficiency.
Okay, thank you for that answer. Could you name just one or two micronutrients that would be deficient in dysphagia, Srimati? I know there would be multiple, but
most common will be a B12, because B12 deficiency would be there for many vegetarians also, and with a neuro, it is B12 is very common, and some micro trace minerals like magnesium and other things. So when you know already, there will be a biochemistry which they would have done a lot of things. So one is prebiotic fiber, which is for constipation. Other one you can look at B12.
Thank you. Thank you so much.
I would like to supplement to this. See, most of the dysphagia patients are, sort of indoors. They rarely venture out. So vitamin D associated with calcium and phosphorus are very, very common with such patients. Apart from whether it's a head and neck cancer or a neuro, as Srimati was making a mention.
Great. Thank you, Meenakshi, for your input. The next question is to Dr. Madhumita. Can ashwagandha be given for Hashimoto's?
I cannot make a blanket statement as to whether it can be given or not. We have seen ashwagandha can be given in most conditions, but Hashimoto's is specifically, even the individual's presentation would matter. So I would say that as a support, if it suits the individual, it can be given to, overcome the weakness, help them with gaining the strength, etc. But we will have to identify other factors which come into play based on the symptoms and presentation in the individual. Because even the same Hashimoto's presenting in two different people will be slightly different. So just for me to say that, yes, ashwagandha is safe to be given in Hashimoto's would be wrong on my part. The presentation, and the individual matters a lot before we can choose the herb in them.
There's just one last question in the chat box, but meanwhile, maybe the tech team can find out if there are any questions from the audience and then share it here, please. Madhu, again, this is for you. Can ashwagandha be given during pregnancy and lactation?
That would not again be the herb of choice, because probably in pregnancy and lactation, the choice would go towards another herb, which is called shatavari. But it's not that ashwagandha cannot be given. It can be given for other factors, specifically to support lactation or to promote, the growth. Shatavari may be more useful, but ashwagandha would probably be helpful in the right gain of weight in both the mother as well as the child, overcoming the exhaustion post-birth, etc. So it can be used.
Thank you so much. Any questions?
I have a question, ma'am.
Go ahead, Meenakshi.
For Dr. Madhumita. I think it was an excellent presentation, Dr. Madhumita. My big query is, are there any contraindications for either Brahmi or Ashwagandha? You see, you've told us very, very clearly how it really helps us. And if you take an overdose, there could be side effects. But there is a big no where it should not be used. Is there anything like that?
Generally, for the rasayanas, that is not the case, in the sense that you don't have a direct definition that says ashwagandha should not be given here or brahmi should not be given here. But through practice, I can surely share that in certain people, like especially like for people who, let's just say, are in the obese category or who have naturally a lot of heat in their body, etc., ashwagandha would not be my choice in them. The reason is because it is hot in potency. I have seen that they react pretty badly to that. Similarly, for Brahmi, I have used, as I said, from children to different age groups and found it to be very effective. But in certain people who have like a lot of hyperactivity, that would not be my choice. Between the two types, also, I may go for the other one, which is more neurologically helpful as compared to, like, between the Bacopa munari and the other one, that is the Centella asiatica. Even between those two, you can choose which one to go for. Because I have seen in certain conditions, not all, maybe one in like a 50 chance or something, that it can increase the hyperactivity if given that Brahmi, the Bacopa munari, in that case.
So probably in ADHD patients, we can, it could be a straight no.
But in that study, it did show that it helps. This is basically based on my practice, and probably I would say that it is helpful where, see, even in ADHD, there is a slight differentiation. Like certain kids, they have more of, restlessness versus certain kids who have the inability to concentrate. So in concentration, this is very effective, but in restlessness, it will not help. So we can use a combination of herbs also in such conditions to help.
And the last question from my end, I'm sorry for barging you with so many questions. The dosage, the acceptable daily intake or the maximum dose you would suggest with reference to Brahmi and Ashwagandha for human population, adult human population and pediatric population?
Okay, so for adult, it's obviously much higher. Even the form in which you give it matters. Like, for example, if you're going to give it as a juice, a fresh juice, then that says it can go even up to 10 to 15 ml. Like it can go from 5 to 15 ml, the Brahmi extract. If you're going to give it like a paste or a powder, then they say between 2 to 3 grams is like the maximum which you can give. But the ideal dosage is much lesser than that, in the sense that when you like take it in the extract form or a tablet, etc., they say in a lower dose, which is anywhere between 500 to 800 milligrams, would be ideal in an adult. Now, in children, it varies because age group also has a role to play, and Brahmi can be given right from birth, right? So in the birth category, that is, I would say in the infancy, they say anywhere between 1 to 5 drops. And when it goes to the childhood, you can go maybe like, I would say 0.5. That's also quite a bit. It varies, but I give anywhere between 100 to 200 mg, depending upon how it's easy to procure for them. Ashwagandha also, I mean, that in adults is, it goes into grams also, where people give up to 1 gram, 2 grams, or even more than that. But ideally, they say anywhere between 250 to 500 milligrams, if I'm not wrong.
Thank you so much.
Great. That was very informative. Thank you so much. Sheetal, do we have any more questions from the tech team or from the audience?
No, ma'am. All questions have been shared.
Krishnamurthy,
Okay,
sir.
Thank you so much.
So Shri, I had one question for your presentation. I think it was amazing. Absolutely. I cannot have any words to say how amazing your session was. But my biggest query is, now say if I've had a lot of patients, even young and adult patients also, where we have issues with water. It's a real challenge for us. And definitely we cannot afford thickeners. So we are like left. So I really want to congratulate you for your, product which you have developed, which sounds very economical, but can that be used for thickening for water purpose for our adult, geriatric and pediatric population?
Yeah, I'm trying to revive it, but the production is not now because FSSAI has come with this different label which says FSMP. which is food for special medical purpose. So when there is a food for special medical purpose, it's a different license and it takes years to get it. So, and also the factory is now closed, like because of the COVID. So I'm trying to see if it is possible for FSMP license. If I get it for that, then maybe I'll revive the product. Is
what else would you suggest for such patients? So we are left in the lurch, really, truly.
Yeah, Gond, Gond which you have.
The guar gum was one thing which was always hitting my head. And currently we have a product which is not very, very expensive. You know, we have this guar gum in the market, which is currently recently launched, and not very expensive at all. If you could share your insights on the usage of guar gum for thickening, for swallowing liquids.
So it depends upon whether it's a powder or a gum or a gel.
It's a powder. It's a powder. It is completely miscible in water, completely miscible. So it looks like water only. So I'm really wondering whether it really does its job.
So the main thing is you have to try that with an SLP. Because that is why the product that has come now by certain company, they are not targeting the nutritionists because only the SLP knows how to thicken because with the water. So the other thing is there is a Gond which is there in North where you see very, very useful, very, very useful, very economical, less than 20 rupees.
Yeah, I agree. I agree.
With the gel. And, we as Indians are very, very famous for the jugaad where we use different things to do it. So I think the Gond, yes, it helps a lot in thickening the water.
Okay, that's amazing. So that was always on my mind, but always skeptical about using it. I don't know why, which always held me from using it. But I keep telling my girls, we have to try this Gond. We have to keep trying and telling them we'll pick it up from, this Naat Marand Kadai from Mylapore. There's one place which
it's there on Amazon. I bought it.
It's on Amazon also. Okay.
Packet Gond. Why I did this is, in a recent SLP Quest conference in Goa, I met someone who was saying that it is there. And when I tried it in water, it was good. But it all depends upon how much you're adding, the gel.
Yeah, that's okay. No, so that we can take the help of the SLP, right? That's great.
Yes,
But that's very economical. It's always been running on my mind, but really not got rock bottom to it. So I'm grateful that there is somebody who resonates with it.
That and guar gum, both as a powder that can help.
Yeah, but guar gum, the one which is available in the market is very, very economical, but it doesn't give any consistency to the water. Though there is a prebiotic and soluble fiber, all of it, but it's completely invisible. And the water is just like water, even after mixing about 6 grams to it. So I think the better option would be we could try with Gond, or reduce the guar gum which is in the market. Instead of the 100 ml, try it in 50 ml, 25 ml and see the miscibility.
You have to do it in 20 to 30 ml, Meenakshi.
Okay.
Because even the thickener which is just that is there in the market is mainly it's mainly because you don't see them, you don't taste it, you don't see it, you don't have any difference. It's like a plain water but goes slowly. So it depends upon the SLP who knows how to give, especially water, because there's risk of aspiration.
Yeah, I know. I think it was wonderful listening to you as well as Dr. Madhumita. I think you gave us a crystal clear understanding of what we were looking at. So if there are any questions, I would request Krishnamurthy sir to take over if he has some questions or queries in his mind. Or we have participants, but I think as Sheetal did make a mention, we don't have any more questions coming up. So I would request Krishnamurthy sir to share his insights on both the topics. Sir is around?
Yes, ma'am.
Yeah.
He has just joined back again.
Okay. It's raining here in Chennai, so we are on and off the radar with reference to internet. So just bear with us. Yeah, there sir is back. Sir, any queries on your end with reference to Dr. Srimati as well as Dr. Madhumita? He's frozen.
Yeah, I think his video is frozen.
So we'll wait for a moment if he can get back to us. Shri, you want to say some concluding remarks?
I just want to thank for the opportunity, and I want clinical dietitians to focus on dysphagia also, because it is increasing and the geriatric population is supposed to, as I said, more than double by 2050. And this is one of the goals by the WHO, International and National Organization. So we need to really play an important role in preventing malnutrition in these people. Thank you.
I think we have overshot.
Sir is back. Sir is back. Sir?
एक मिनट
Sir, you have any queries with reference to Dr. Srimati as well as Dr. Madhumita?
Srimati, excellent talk. They practically and theoretically you have to evidence proof here. Basically, practically how to using and planning.
Thank you, sir.
Thank you so much, sir. Dr. Madhumita, your closing remarks?
I think my closing remarks would just be that when we plan to do herbs or use herbs, it would be ideal to collaborate. We were talking about integration, so I think collaboration and integration is very important, and not take them as over-the-counter drugs, because then there are more chances of complications occurring and negative reactions to these herbs occurring.
Yeah, I think we've seen most of it during COVID. It's like crazy. People have gone, bonkers with reference to using turmeric and kadas and all of it. And some of our CKD patients had come to us with 6.77 potassiums, and it was crazy. So I think that's the role where we have specialists who can tell us the prescribed doses, because it was being just given away in large quantities like crazy. Thank you so much. I would request Raji to take over.
Thank you, ma'am, for the dense content of information, and every minute we view it as such a valuable contribution by each and every speaker over here. I now request Dr. Bhavani, Chief Dietitian of ESI Medical College and Hospital, Secretary of Indian Dietetic Association, to give the vote of thanks.
Good evening, one and all. At the outset, I'm glad to propose the vote of thanks on behalf of Indian Dietetic Association Chennai Chapter, Netrofran Chennai Chapter, and Good Monk. I thank Mrs. Srimati Venkatraman Madam, Clinical Dietitian and Wellness Nutritionist, for her extensive and valuable inputs on dysphagia. Thank you very much, Madam. My sincere thanks to Dr. Madhumita Krishnan, Consultant, Ayurveda Physician, and childbirth educator, for an interesting and informative session on benefits, safety, and efficacy of Ashwagandha and Brahmi. Thank you, ma'am. I extend my sincere gratitude to Mrs. Sheila Krishnaswamy, madam, diet nutritionist and diet nutrition wellness consultant and former national president IDA, for accepting our invitation to chair this session. Thank you, ma'am. I thank Krishnamurthy sir, convener, IDA Chennai chapter, for chairing the session. I thank Meenakshi Bajaj madam, convener, Netrofan Tamil Nadu, for her valuable inputs and chairing the session on dysphagia. I thank Mrs. Deepa Govindrajan madam, co-convener, IDA Chennai chapter, for her warm welcome address. I also thank Mrs. Rajeshwari, treasurer, IDA Chennai chapter, for her mind-blowing master of ceremony. I thank the office bearers of IDA Chennai chapter and Gold Monk for organizing this wonderful event. I also thank the students, faculties, dietitians, and IDA members for participating in this scientific session and made this event a grand success. Thank you all.
Thank you, ma'am. Thank you, Bhavani. I request all to stand for the national anthem.
Dravid
you, ma'am.
Thank you so much to one and all present here. Sheetal, can we request everyone to, have their videos on? We can have a picture.
Yes, may I request everyone to switch on their videos?
Sheila ma'am.
Picture. Bhavani ma'am and Rajeshwari ma'am.
Krishnamurthy sir, yeah. Yeah, Deepa. Bhavani. We have Bhavani in.
No, we're just waiting for Bhavani.
I think we'll go ahead. Bhavani is missing.
Fine, thanks everyone.
Thank you so much. I think it was wonderful. Wishing one and all a great Diwali and a great weekend. Thank you so much.
Thank you all.
Thank you.
Thank you all. Happy Diwali.
Yeah. Happy Diwali to everyone and all the best.
Thank you.
Good morning.
Take
Thank
care.
you.
Bye.